Hello and welcome to today's webinar. Thank you for joining us. My name is Sarah Muller-Robbins, and I am the Director of Education for the Partnership for Maternal and Child Health of Northern New Jersey, which is providing today's program. Our webinar today is titled The Intersection of Interpersonal Violence and Health, Critical Considerations. I would like to review some information before we get started. Immediately after the webinar ends, as well as in an email, you will be invited to take a post-program evaluation. We appreciate your feedback, so please complete the survey. To receive a certificate of completion, you must listen to the entire webinar and complete the evaluation survey. Certificates of completion will be sent via email within 1 week of the webinar broadcast. This program is being recorded and will be available on the Partnership's YouTube channel. We will be muting all attendees' microphones during the presentation, but we welcome your questions and comments. Please use the question box, and the speaker will respond to as many as possible at the conclusion of the presentation. Now it is my honor to introduce today's speaker. Linda Sloan Locke brings a multidimensional background in social work, midwifery, public health, and nursing, with a commitment to working with populations who have been historically underserved and marginalized to her direct service and consulting roles. With an expertise in serving women, adolescents, and birthing people in a variety of settings, Linda focuses her work on the intersection of health and mental health, perinatal and adolescent mood disorders, social and reproductive justice, and intimate partner violence and sexual violence. Welcome, Linda. Thank you so much for joining us today.
Thank you, Sarah, for having me today. So this afternoon, we're going to look at intimate partner violence from a slightly different lens, and that is the intersection with health and its impact on health. So I want everyone to sit back in their chair, get a little bit grounded, ground your feet on the floor, and understand that some of the things we're talking about this afternoon may be uncomfortable. If it comes up in you that you feel uncomfortable when you're watching some of these slides, just be aware of that and give yourself space to process. I want to also share with you that the partnership has 4 other webinars on their website and on their YouTube channel, which were recorded last year in 2020, that go into domestic violence in with another angle. They will identify the dynamics of domestic violence, focus on methodologies for screening and reporting responsibilities, teen dating violence, and strangulation in more depth. So for those particular areas of the domestic violence and health conversation, I encourage you to take a deeper dive by viewing those additional webinars. Today, as I said, we're going to look at domestic violence a little differently through the lens of health. So first of all, how do we define health? We know the WHO defines health as a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. The Lancet says that we need to adapt to our environment to achieve health. And we know we don't exist in a vacuum, but interdependent existence with everything in our world. And we know that all of those things are called the social determinants of health. You know, in the past 10 or 15 years, we've been talking about these a lot. We know that childhood experiences, housing, things like lead in the water, air pollution, adequacy of income, what our housing looks like, whether it's stable or unstable, all of these things have an impact on our health. And most of us now know about the ACE study from the 1990s, which came from California, and for the first time linked childhood trauma to long-term health and social consequences across the lifespan. The ACE study identified 3 buckets of ACEs with 10 different categories. So abuse, childhood, household challenges, and neglect. And they identified that there was a dose-related relationship. In other words, the higher the ACE score, the more ACEs that a child experienced, the more likely they were to develop problems in their health and social well-being throughout the lifespan. What you may not know is that the ACE study continues. It is now called the Behavioral Risk Factor Surveillance System, and it's annually done in 49 states, the District of Columbia, Guam, and Puerto Rico. And we see that the number of ACEs really has stayed pretty stable. The initial ACE study was done with a very specific population. The current BRFSS study is much more varied, takes in more different kinds of people, but we're still seeing that about 60% of the population has experienced at least one ACE. And the impact of ACEs are that over the lifespan, the more ACEs a person has experienced correlates with an increased risk of poor health and impact on well-being throughout the lifespan. Philadelphia took it a little bit further and looked at community-level adversity and how these experiences of trauma in childhood impacted health. They looked at witnessing violence, feeling discrimination, living in neighborhoods where they did not feel safe, being bullied, and experiencing foster care, and discovered that just as family-level ACEs impacted health outcomes throughout the lifespan, community-level ACEs did as well. We also now know that this goes beyond the experience of the individual through intergenerational trauma, which is the cumulative emotional and psychological wounding over the lifespan and across generations, which comes from massive group trauma experiences such as genocide, slavery, massacres, pandemics, forced relocation, systemic racism, and prohibition or destruction of cultural practices and native language. When we look at health outcomes, what is really important to remember is that 60% of our health outcomes are determined by these social, environmental, behavioral factors. And 10 to 20% are healthcare and 10 to 20% are genetics. So these are important determinants of our health. So then when we look at domestic violence as a social determinant of health, first we want to make sure that we're using the same definitions, that we're clear on what our definitions around intimate partner violence or domestic violence is. IPV is considered a pattern of assaultive and coercive behaviors. And it's not just physical violence, although physical violence is a very big part and an important part, as I'll reference in a little bit, but also psychological abuse, sexual violence, stalking, psychological aggression, intimidation and threats, social isolation or deprivation, economic or reproductive coercion. And the purpose is to gain power and control over the victim. So a couple of the terms I will use interchangeably are DV and IPV, and also I'll use interchangeably victim and survivor. But I want to make clear that the person having the experience must be the one to come up with the definition of whether or not they consider themselves a victim or a survivor. This is not something we can define for them. The person must define it for themselves. So you're probably familiar with the power and control wheel, which identifies the different areas in which domestic violence or intimate partner violence can be experienced. And we know the statistics. Between 1 in 3 women and 1 in 4 men have been abused. If you look at numbers of severe physical abuse, it's 1 in 3 and 1 in 5. We know that it accounts for about 15% of all violent crime. We know that 75% of us, 74% of us personally know someone who has been a victim of domestic violence in the past year. This year's Domestic Violence Month, one of the banners was "Everyone Knows Someone," and that really is very true. Almost every one of us knows someone who has been a victim or survivor of domestic violence in their lifetime. In New Jersey, an act of domestic violence happens every 7.5 minutes. And in 2019, 62% of female homicide victims were killed by an intimate partner. If you look at this, is the significance of this, if you compare to men, only 5% of men are killed by an intimate partner in the same year. The CDC also gives us a definition of what is an intimate partner. That's a person with whom one has, excuse me, a current or prior close relationship characterized by emotional connectedness, contact, which can either be physical or sexual, and familiarity and knowledge about each other's lives. So it can include a spouse, a dating partner, a sexual partner, a prior dating partner. And they also define physical violence as the intentional use of physical force with the potential for causing death, disability, or harm, or coercing another to commit such acts. New Jersey domestic violence law very specifically identifies domestic violence victims as persons over 18 as opposed to child abuse. It identifies people who are emancipated and therefore can be considered victims of domestic violence, and identifies all of the areas that domestic violence includes. And this is really important from a prosecutorial viewpoint for the legal system: homicide, assault, terroristic threats, kidnapping, criminal restraint, false imprisonment, sexual assault, sexual contact, lewdness, criminal mischief, burglary, harassment, and stalking. So I'm going to talk a little bit now about how people who live in different bodies experience domestic or intimate partner violence. And we know that IPV is pervasive through every community, every socioeconomic group, every ethnicity and culture. But it's also important to understand the impact and intersection of social determinants of health, identities, as factors that play into how a person, an individual, experiences and lives through the experience of intimate partner violence. For Black and Indigenous people in this country, there has been historical problems with recognition of whether or not they can actually be victims of domestic or intimate partner violence. Historically, institutionalized rape and rape laws that only identified white females as a person who could be a victim. There have been legal and jurisdiction issues, and continue to be, for Indigenous people. Anytime a crime takes place on Native land, there may be 3 levels of legal jurisdiction: federal, local, and tribal. Stereotypes and myths can play into how the experience is seen, not only by those of us who care for people, but by people as they move through this experience. For instance, this myth of the Black superwoman, especially if it's internalized, we feel, well, I shouldn't need any help. I'm a Black woman. I am strong. I should be able to get through anything on my own. We all know, we've been talking about more and more how we all hold biases and how culturally in our country these biases play out. And some of these biases can also be at play here. Barriers to disclosure could include, again, these internalized myths, reluctance to report, concerns that the community will look poorly on you if you do report. And we've seen in the Black community, unfortunately, the Black churches over the years have been a culprit in this area. They have not been supportive of people getting out of the situation, and that is changing. But these are the kinds of things that people are dealing with when they're trying to make decisions about how to respond to living through this experience of domestic violence. Barriers to disclosure are not being concerned that they will not be believed, mistrust of systems that were not set up to serve them, fear about police in this post-George Floyd era. We have a heightened awareness, I think, throughout our culture that police brutality and disproportionate arrest takes place. If you are a Black person who is considering reporting to the police, you may be more afraid of the police than you are of the perpetrator. The other flip side of that is that you want the violence to stop, but you don't want the person to be killed by the police. And these are very real fears that people have. There's a disproportion in rates with more than a 50% incidence for Indigenous people of both IPV and sexual violence. There is a move now because there are over 5,000 murdered and missing Native Indigenous women in our country because of some of the problems with legal and jurisdictional issues. Many of these women are felt to be victims of intimate partner violence. For immigrant, Latina, and Asian people, again, stereotypes can lead to people not being as aware that things are happening in this area. And stereotypes and biases about different types of people and whether or not they are submissive, whether or not they are sexually available, concerns around trafficking, cultural issues in the home culture. For a person who has migrated to the United States, there may be even more stigma around intimate partner violence and internalized self-blame. Immigrant status can mean that a perpetrator will isolate the victim, use their immigrant status as a threat. They may come from countries in where the legal and court systems are very different from here. In some countries, victims are not allowed to speak in court. In some countries, the judges must be paid by the family if a case is to be brought. So the differences in the systems can be very confusing, and you layer this on top of differences in language, so that there can be a lot of different cultural and things that can inhibit a person's ability or think that they cannot report. And then when they do report, if they do seek out services, are those services linguistically and culturally appropriate? People with varied abilities, chronic health conditions. We know that women with disabilities, regardless of their race, ethnicity, sexual orientation, gender, or class, are assaulted, raped, and abused at twice the rate of those without disabilities because of their increased or perceived increased vulnerability. Adults with developmental disabilities are 4 to 10 times more likely to be assaulted than other adults. We need to remember when we're interacting with patients with varied abilities that the level of ability or disability may impact their options of choice with whom or where they can live, their freedoms to come and go, opportunities to make decisions about their bodily functions, a career, or their ability to have a sufficient income. In the LGBTQI+ community, IPV happens as well. Even though the dominant culture has perceptions and/or biases of what constitutes IPV, we know that our typical picture in our mind is of a man who is assaulting a woman, but this occurs across all genders, excuse me, and we need to be aware of that. We also know that transgender people have greater marginalization and discrimination, that LGBTQ specific emotional physical IPV can center on their gender identity to exert power and control. And again, in this community, there is often reluctance to report. We have levels of stigma, disbelief, fear that the resources may not be sensitive to their needs. Up until recently, that was very common, that to go to a shelter, if you were a transgender woman, you might not be able to take advantage of those services. And elder abuse and violence occurs frequently in our country also, and in the patients that we take care of. Although only about 10% of elderly people will report abuse in a year, but we estimate that only 1 in 14 cases are actually reported due to fear of loss of support, retaliation, inability due to physical or cognitive status. And if an elderly person has dementia, it increases the risk of abuse by 45 to 50%. There is high levels of financial exploitation, and when we look at the impact on health, elderly people who experience abuse have a 300% higher rate of risk of death or compounding health problems in the year after the abuse. And what about those of us in the United States living with a mental health disorder? That's a lot of us. Almost 50% of US adults will experience a mental health disorder in their lifetime. And in any given year, 25% of us will have a mental health disorder. So this is common. People living with a mental health disorder are more vulnerable to abuse, with rates that are quoted anywhere from 44 to 85% higher than those without mental health issues. Again, batters or perpetrators will use these issues to control their partner, because this is what domestic violence is about. They'll control medications and treatment, undermine sanity and the person's ability to parent. And sometimes the symptoms of trauma that the patient presents with to us can be misdiagnosed as mental illness. So then let's go to the health implications of IPV. We've established that social determinants of health and trauma are definitely things that can impact health and health outcomes. But we also know that there's physical violence that takes place in IPV. And so how does that impact health? For physical injuries, about 90% of all injuries are to the head and neck. 56% will involve fractures, especially of the smaller bones of the face. They can be blunt force, sharp force, bite injuries, burns, traumatic alopecia, which is from hair pulling, or defensive injuries. And dental trauma, fractured teeth or jaws, tooth abscesses due to traumatic fractures of teeth, injuries to the palate and the gums. In fact, the dental profession has a specific training on domestic violence, because very often dentists are the first people to see someone after they've experienced this kind of an injury. And strangulation is very common as well. 10% of people who will experience IPV will experience a near fatal strangulation. Many more will experience some kind of strangulation while they're in a situation with domestic violence. And to be clear, it is not choking. Choking is the obstruction of your airway, usually by food. Strangulation is the obstruction of blood vessels and or the airway in the neck, resulting in asphyxia or loss of oxygen to the brain. The neck is the most vulnerable part of our body. It doesn't take a lot of pressure to occlude the jugular or the carotid artery, less than it takes to open a can of soda. And the amount of pressure to block the trachea is less than a handshake. It only takes about 6 to 10 seconds to lose consciousness. And when you lose consciousness from occlusion of a vessel, a major vessel, brain cells begin to die. In 15 seconds, a person will lose bladder or bowel control. And survivors will describe this as, he choked me and then I woke up on the floor. That means that they have lost consciousness. This is a significant predictor for future lethal violence. If you were strangled by your partner, it increases the lethality risk 7 times. And it's important to know that symptoms may take days or weeks to show up, and that not always are these signs and symptoms readily seen or readily available. In fact, 50% of the time, there are no visible signs of strangulation. There can be delayed fatal or near fatal complications, such as carotid dissection or hematoma. And this shows a summary of the signs and symptoms of strangulation that can be found on this Training Institute for Strangulation Prevention, which is in at the end, the slide at the end as well. But again, 50% of the time, none of these will be visible, especially bruising around the neck or petechiae to the face if the person is more dark-skinned. So what is this about IPV and TBI? So when we think of traumatic brain injury, first of all, it's defined as injury to the brain caused by external physical force. And what do we think of? We think of people who've been in the military, right? Or maybe now we think of NFL football players. Sometimes we might think of someone in an automobile accident, which is motor vehicle accidents are also one of the very important causes of TBI. But we know that this happens in domestic violence as well. It can be from a closed head injury or from cutting off oxygen with strangulation. Mild to severe, it is a major cause of death and disability in our country and accounts for 30% of all injury deaths. Victims also are not aware, especially if they did not lose consciousness or did not go to the ER, that they may have sustained a traumatic brain injury. And it's important to understand that repeated injuries can cause a cumulative effect. So TBI is a concussion, and we know that there's the initial impact and then the secondary impact, coup contre coup. For those of us in maternal health, we know that IPV is a very serious complication when we come to pregnancy. First of all, the very act of becoming pregnant may be because of reproductive coercion. Perhaps the partner has thrown the pills down the toilet, poked holes in the condom, prevented a person from keeping their visit with a practitioner to obtain birth control, because in order to have control over that person, they want the person to become pregnant. There can be an impact on prenatal care with delayed onset and missed visits. We know that people who experience IPV are at increased risk of spontaneous abortion, preterm labor and birth, low birth weight, anemia, poor weight gain, infections, labor complications, worsening of chronic conditions, and other poor pregnancy outcomes. And since November is Prematurity Awareness Month, we want to remember in our concerns about preventing prematurity to make sure that we consider IPV. We know that there's an increased risk of perinatal mood and anxiety disorders, increased risk of perinatal injury and death from trauma, and indirect effects to the fetus, especially the chronic stress that the mother may be under, we now know may have a long-term impact on fetal and infant development. And we know, unfortunately, the domestic violence will escalate with the onset of the pregnancy. The risk of physical violence doubles, and the abdomen is a frequent target during IPV with a pregnant woman. Pregnancy does not protect the mother from partner homicide. Homicide is a leading cause of traumatic death for pregnant and postpartum women. It accounts for about 30% of all maternal injury deaths. And in the first year postpartum, partner homicide accounts for 43% of postpartum deaths. So when we're looking at the impact on maternal health, this is an important thing to remember. So after the bruises fade, long-term and ongoing health effects of IPV. And these bruises are not just physical bruises, although we'll start with those, but they are also emotional and psychological bruising as well. So we know, since we're talking about traumatic brain injury, we know that it can affect daily life in both the short and long term. Depending on what part of the brain has been injured, there can be lack of focus, irritability, problems with language and reading, blind spots and blurred vision, problems with memory, walking, slurred speech. There can also be an impact on the neuroendocrine function. Injury to the brain can affect the pituitary gland, which we know controls activity of most other hormone-producing glands. And neuroendocrine function can cause a variety of symptoms: fatigue and weakness and muscle cramps, depression, poor memory, weight loss, blood pressure changes, menstrual cycle changes, even infertility. Vision, about 20 to 40% of people post-TBI have vision problems, problems with cognitive issues, sleep disorders, and the hippocampus, which is critical for ongoing organizing and storage of memory, is very sensitive to oxygen deprivation. And so TBI, and especially strangulation and oxygen deprivation, can have an effect on the hippocampus. This is the HELP screening tool for traumatic brain injury. It's available online, and it goes through, if somebody does report head injury, whether or not they lost consciousness, And did they have any problems after being hit on the head? So besides the physical impacts and the physical effects, we know that experiencing intimate partner violence can obviously cause toxic stress, which will cause an excessive and prolonged activation of the stress response systems in our brain and body. We know that if the stress is extreme and long-lasting, the cumulative impact on physical and mental health can be significant. We see that there's an elevation of inflammation in every part of the body and elevated cortisol levels, and then we see increased problems in health outcomes, increased rates of stroke, heart disease, asthma. So really affecting every part of the brain, every part of the body, and every system. So people who have experienced IPV have higher rates of migraines, sleep disturbances, circulatory problems, gastrointestinal disorders, central nervous system problems, cardiovascular disease, hypertension, asthma, fibromyalgia, joint problems, PTSD, sexual dysfunction, headaches of all kinds, bladder infections. We see now that sometimes people are being injured in a place where that's covered by clothing, so it won't show. So they're being hit in the back, in the kidney area, so that can be a problem. But also the chronic stress can impact every system in our body. And chronic stress obviously can cause us to have an intersection of IPV and mental health. We know that people that have lived through and are living through the experience of domestic violence have increased rates of depression, anxiety, PTSD, substance use disorders, eating disorders, and suicidality. And when we look at depression and we look at the typical screening tools that we use, here's one. It's very, we also use the Edinburgh. But if somebody is feeling scared, anxious, and panicky and is living in a situation with intimate partner violence, then that may not be a symptom of depression. It may be directly and a direct effect of the fact that they're living with intimate partner violence. So we need to use that, have that information to use as a backdrop so that it can inform our interpretation of the depression screen. We don't want to minimize the fact that there is definitely an increased risk of depression for people that are living with or have lived with IPV, but we also need to look through the correct lens as we're evaluating those results. And then we also see that there is overlap in symptomatology between depression symptoms and TBI symptoms. So again, having the complete picture is really important. And again, for PTSD and TBI, people who have a history of IPV or who are in a current situation of domestic violence are at increased risk for PTSD. They're also at increased risk for TBI, and there is an overlap in those symptoms. So how big an issue is this for healthcare? What is the scope of the problem and the healthcare impact? The annual health costs of IPV are about $8.3 billion a year, which is certainly a significant impact on the healthcare system. This is the direct cost of medical and mental health care, acute care costs, and the care of over 1 million injuries annually. Long-term costs factor in this as well, because IPV causes chronic and ongoing problems in the health space. The impact on healthcare costs persists up to 15 years after the cessation of the abuse, and survivor lifetime healthcare costs are 18 to 30% higher than those that have never experienced IPV. And then there are also the indirect costs, such as lost productivity. So how do survivors interact with the healthcare system? Somebody who's had this experience or is currently having this experience for that person, fear and anxiety can factor into disrupted utilization patterns, which is the way I say non-compliant, because I hate non-compliant words. I'm calling it disrupted utilization patterns. So I'm challenging you all to remove non-compliant from your vocabulary. Issues around follow-up can relate to survivors' difficulty with trust and authority and power and control, or can relate to how their partner is exhibiting control and continuing to control their actions and their ability to take advantage of their health care. When survivors are interacting with the healthcare system, seemingly benign experiences can trigger disturbing memories. There may be systems barriers, mixed gender waiting rooms, long waiting periods, questions by scheduling staff that raise anxiety levels, and home may not be or feel safe. And when we ask people that question, do you feel safe at home? People can answer in a lot of different ways, but we need to make sure that we're being specific about whether or not we mean violence versus, say, a rat or a cockroach infestation. Particular healthcare settings can be particularly anxiety producing for people who've experienced IPV. Reproductive health care, obviously, because of positioning, the power disparities, the discomfort, the relinquishing of control. Dental care is the second most uncomfortable, again, positioning and being very invasive, physical therapy, and any invasive or uncomfortable procedures. So I think we can all agree that domestic violence is a traumatic event. And SAMHSA's, it certainly fits into SAMHSA's definition of an event, a series of events or set of circumstances that is experienced by a person as being physically or emotionally harmful or life-threatening, that has lasting adverse effects on that person's functioning, mental, physical, social, emotional, or spiritual well-being. And so that takes us to the importance of utilizing trauma-informed care. And I'm sure you've been in other webinars that have talked about trauma-informed care, but I want you to think about it today in the space of domestic violence and how we not only interact with our patients and clients, but how we do screening in that trauma-informed way. And utilizing those 4 R's of trauma-informed care, realizing the widespread impact of trauma, understanding the potential paths for recovery, recognizing the signs and symptoms, responding by fully integrating our knowledge about trauma into our practice, and resisting re-traumatization. So you may not be familiar with this medical power and control wheel, which identifies the way in which we in the healthcare system can re-traumatize our patients and our clients when they come into the system, and highlights the importance that we understand that any person that presents for care may have a trauma history, may not have been ever disclosed, and they may have endured the trauma, which today we're talking about IPV specifically, without any support or interventions. They may have disclosed, and that may not have gone well for them. It may have been a negative or re-traumatizing experience. And so it's really important that we have an environment of care that is trauma-informed for all of our patients and clients, which means we inform before we perform. We get histories from people while they're fully dressed. We insist on the availability of privacy for every patient. We avoid phrases that are used often by perpetrators, just relax, and we always get consent for touch. So just reviewing some of the key principles of trauma-informed care: safety, collaboration, mutuality, empowerment, voice and choice, and respect for cultural and historical and gender issues, recognizing a survivor's need to be respected, connected, informed, and hopeful, excuse me, and recognizing the relationship between trauma and presenting symptoms. We know what the barriers are. We know that our society is a very victim-blaming society. We know that organizational and system barriers, time issues, lack of flexibility occur. We know that as providers, our own discomfort, our worry about opening Pandora's box, can be an issue. And if we look at those statistics, right, 1 in every 3 women, we know that somebody in the room every time we hear this talk has had that experience either themselves or someone in their family or a close friend. And so it can be uncomfortable and difficult to hear some of the things that our clients bring to us. And the survivor may have barriers to opening up and talking to this with their provider: guilt, embarrassment, shame, stigma, fears of being judged, and cultural and family beliefs like we went over before. So SAFE is a framework that we've developed in the organization New Jersey Healthcare is about domestic and sexual violence to give a framework for providers to screen, assess, facilitate referral and recovery, and educate and empower. And we should screen by universally screening all clients, all patients about current or past IPV in private. And it's essential to have privacy policies. I know that this is very difficult in some settings, especially say in triage and labor and delivery, been there, done that. But there are ways that we need to make sure that every patient that we see at some point has the ability to speak in private with their practitioner. Remember, the disclosure or leaving is not the goal. We want to develop trust and establish that we care. We can frame the question like, so many people have experienced violence. We're asking everyone, so we make sure we give the best care. We want to make sure that we're non-threatening, non-judgmental, culturally and linguistically appropriate. So USP STF in 2019 gave a B rating to screening all women in reproductive age and all vulnerable people, so people with a variety of levels of ability and elderly people. But we really should consider at least asking some questions of everyone we see. So if a person discloses, we want to assess, acknowledge, and assist for safety, assist with beginning of safety planning, and acknowledge the impact on health, assess the health effects, do a physical assessment, assess the need for the ED. If somebody tells you that they were strangled yesterday, that person needs to go to the emergency room for evaluation, or the need for other referrals, say back to primary care for possibly going to a neurologist for TBI symptoms, and connect their experiences to their symptoms. So a lot of times when we do screening, we're just asking for current situation, right? And a lot of the screening questions that are utilized just talk about, have you had this experience? Have you had any of these experiences in the past year? So I'm going to give you an example of how it can impact our care and health outcomes to know the history. So I had a young woman who I was taking care of doing her prenatal care when she was 17. And she was in an abusive relationship that was both emotionally, physically, and psychologically abusive. And then on top of that, she was incarcerated. During that pregnancy, she had experienced intimate partner violence and incarceration. She delivered at 26 weeks. Fast forward about 2 years, she comes back. She's now 19. She's in a new relationship, a very supportive relationship. Her partner is employed. They have stable housing. And so we did some discussion on her initial prenatal visit about how we were going to look at this pregnancy and what kind of care we were going to give her because of this history of preterm birth. She was a brown woman. And she said to me, you know, I really believe that it was because of all of the stress that I endured in that first pregnancy that I delivered prematurely. And none of that well, she didn't say it exactly like this, but none of that is present now. None of that's going on. Everything is very stable. And so we did share decision making, and we decided, no, we weren't going to give her Makena. And she agreed that we would do some cervical lengths and we would watch that. And that she would let us know if anything in her situation changed, but it didn't, and she remained very stable and very well supported throughout that pregnancy, and went on to full term and actually had to be induced at 41 weeks. And I give that to you because it's important to include history of intimate partner violence in how we develop our plan of care for patients. If we hadn't had that information and we just looked at the fact that, oh, here's a teenager that delivered at 26 weeks before, well, she has to have Makina. And then when she didn't come in for the shots, we would label her that horrible word, non-compliant. So I just wanted to give you that experience as kind of an illustration of how important it is to get a history of intimate partner violence as well as the current situation. So the F is for facilitate recovery and referral and recovery. So we're going to provide referrals to resources. We want to know what our internal resources and policies are, familiarize ourselves with domestic violence resources. Every one of our 21 counties in New Jersey has a domestic violence agency. And there are also additional agencies that are culturally specific, such as Manavi, that is specifically for South Asian women. Well, we know warm handoffs are best. Sometimes a person will say, okay, I do want to call this hotline, but I don't want to leave this room and do it. I want to do it in here. And maybe we should be open to doing that. If we're referring somebody, we might want to ask if they've ever gone to that agency before. We don't want to send them somewhere that they have been and had a bad experience. Acknowledge their need for readiness, present options, leave the door open to talk another time, because we know that empathetic support facilitates healing. And then educate and empower, validate their experience. It was brave of you to share this information with me today. Encourage people to self-define their experience, listen, believe, and support their autonomy. You are not unique, but you are unique, but you are not alone. You are not to blame. And universal education. I want to, even if a person does not disclose any current or past intimate partner violence, we can always share resources with everyone. I want to share this information with you today. You can use it when you're ready, or maybe you may have a friend or family member that can use it. Remind them that violence does worsen over time. But the good news is that people that talk to their provider are 3 times more likely to use services than if that discussion has never taken place. I want to just briefly mention some modifications for telehealth. When we talk about privacy and making sure that we're in that private situation, we may not be able to know that if somebody is on a screen. We don't know who's on the other side of that computer. So we need to talk about confidentiality. When this is a particular thing that's from Futures Without Violence, it's called Q's, and the C is confidentiality. So starting off that we're having this conversation, but your medical information is confidential and doesn't change just because you're not in the room. So are you okay to talk now? Can anybody else in the room hear what I'm saying? And if they say, yeah, there are other people, or no, I don't feel like I can really talk now, are you able to move to a place where you can feel more comfortable? Can you put headphones in so nobody can hear what we're talking about? Would it be better to find another time to talk, or move our conversation to messaging, or can I text you? So making sure that we get that permission to enter into sensitive conversations with people when we're not face to face and we don't know who else may be able to hear what's going on. And especially because, during COVID, we know that very often people were isolated with the perpetrator, with the person that was abusing them. And then for Q's, the UES is universal education and support. So they suggest that you put this information up on like a screensaver when people are maybe in the waiting room waiting to talk to the practitioner. You can also print this out and use it in the office, and use this to give people, as far as I like to share this information with all of my patients, because we've been going through all these crazy times, and so many people need help with so many different things, and hiding the, like including the domestic violence hotline information in there, but also having the hunger hotline, the parenting hotline, the crisis hotline, where you can go to get food. And that way, if the perpetrator then sees this handout, it's not glaringly obvious that you're referring them to domestic violence services. If the patient or the client discloses, you're going to do go through the same steps as you would in person, but sometimes you can set up a system where you can connect the person right away without them hanging up, have a way to connect them to services if they're ready to seek services, or they're ready to leave, or they want to take advantage of some of the services that are available. Connect the conversation to the reason for the health visit by talking to them about how IPV and how this experience can impact their health, and that you're really concerned about your health, and so this is why you want to really have this discussion. Survivors say, I'm glad someone finally asked me. I think everyone should be treated as if they were a survivor. And my idol, I've learned that people will forget exactly what you said. People may forget what you did, but people will never forget the way you made them feel. And those are, whoops, sorry about that. I don't know why that resource screen didn't want to stay up there. We have these resources, and when obviously if you want to look at the tape, and you can take down the resources, there's a couple here. ACEs Too High is really something that you can share with clients and with patients. It talks about ACEs in a very user-friendly way, and talks about how some of these experiences can have long-lasting effects on our health. Strangulation Institute, Pink Concussions is an organization that addresses the effects of traumatic brain injury on women. And then New Jersey Coalition to End Domestic Violence is the New Jersey state organization that supports domestic violence services throughout our state. And thank you. Thank you very much for being here this afternoon.
Great. Thank you, Linda. That was a lot of information and resources. I'm happy to share some of those resources in a follow-up email too with the participants. We do have a few questions, and the question box is still open, so if you have questions, please feel free to enter them. One comment and question is, I have a male relative who is a survivor of IPV. He's going through the effects: embarrassment, guilt, mental health issues, anger, etc. Do you see an increase in male victims, survivors?
So I don't know if there's an increase in actual numbers. I think there's an increase in people that are identifying themselves and reporting. Because as we become more aware that a variety of different types of people can be survivors or victims of intimate partner violence, people are coming out. And I mean, we know that for instance, for child abuse and child sexual abuse, the average time that it takes from the incident to reporting is about 15 years. So we know that when there's stigma around reporting, stigma around giving that, sharing that information, as that stigma slowly is being addressed, there are more people that are reporting this. So I don't know that we'll ever know whether it's actually a finite increase, but I think the availability of services for people, because 10, 15 years ago, if you were a male and you had a problem, where would you go? Because all of the programs were geared to women, and many of the women's battering shelter, battered women's shelter. So there wasn't anywhere for you to go. And now almost every county has support groups and services that are directed specifically to men. So that's a great question. Thank you for asking.
Thank you. We have a couple more questions. You mentioned churches have not been supportive of those who've experienced DV but are starting to change. Can you give an example of a church's role?
So I think it's important to understand as a minister, as a clergy person, as a person who is in the church, that very often they take on a counseling role with individuals and families in their congregation. And over the years, we've seen more awareness of clergy counselors that domestic violence is something that is a very serious thing, and actually them getting training so that they can really give appropriate counseling. For instance, in the past, what clergy might do is to have the couple come in together to do couples counseling with them, which 9 times out of 10 is not the right way to go. So it's just, again, getting this awareness out to a variety of people in the community so that people are going to address this in an appropriate way, are going to address it in a way that is not going to put the victim in more danger. The danger of, bringing those two people together to talk to them is that when they leave the office, 9 times out of 10, what will happen is that the perpetrator will be more angry at the victim and the abuse will escalate. And so having that knowledge is really important for people that are taking on counseling roles in churches.
Okay, thank you. Another one is, do you have suggestions on ways to change the culture of medical care to be more trauma informed? Because culture change is so hard.
In 20 words or less? I mean, I think it's a big task. It's an important task. There's a variety of ways to do it. I mean, you can start bottom up or top down. If you have a system or a hospital or an organization in which the people at the top are really committed to this, that's the best way to convince them that trauma-informed care is really an important thing to do. If that's not the case, you could start small. You could do it in your particular section of the institution in which you're working and institute trauma-informed practices, have these discussions with your coworkers and your colleagues. Ideally, it would be a system-wide thing, but that's not always possible. So starting somewhere is better than doing nothing, I think.
Another one, is there a way to develop a QR code for resources to help women or men experiencing IPV? We have one at our hospital, help with breastfeeding families.
That's a really, thank you for that question. That's not I mean, that's an idea. I think that's an excellent idea, and I don't see why not. We could, with technology, we should be able to do that. And I would love to connect to the person that has that, is utilizing that technology, because I think we might be able to connect with some of the DV resources in the state to see if something like that could be developed. Thank you for that.
Yes. Thank you to the questioner. I have one other one. Are there programs and services for children who have witnessed domestic violence?
Yes. So each of the, so you can go on the NJC-EDV website to get the information about each of the county domestic violence service areas and service organizations. And almost every county has a children's program as well. So thanks for asking that question.
Okay, great. And I think that is, oh, one more. Is there a particular screening tool that you recommend?
There is not. And so if you look at the other, one of the other webinars, they do go through all of the different screening tools. None of the screening tools has really been recommended by the people that really do all of the research of this, and it's because there's a few that have been validated in 1 or 2 languages, but we don't have the IPV equivalent of the Edinburgh. Like that would be great, right? Because we can all use the Edinburgh, and it's really been validated in many, many, many languages, but we don't have something for IPV that has really been shown to be really the best tool to use. I usually suggest to, certainly if your organization has a tool, you can do that. But I usually suggest that people find a few questions that they can ask that they are comfortable with, because believe me, if you're not comfortable asking the question, your patient will know, right? So you need to be able to ask the question that you're really comfortable asking in a way that you're comfortable asking it, that is in a very, non-threatening and a very open way. But that may not be the same question for everyone. We want to all frame it in that framework and say, you know, I'd really like to ask if you've had any experiences like this in the past, or is this currently happening to you? And I ask you because it's important for your health. I ask everybody. If you don't feel like sharing that with me today, it's fine too. But anytime you know, if you're having those experiences and at some point you want to discuss it, I'm here. You know, really not so much the exact words, but the feeling, right, that you give to that person, that you're really interested, that you may be a real help to them if they have this experience, is I think the important thing.
Okay, well, thank you so much. This has been very helpful and a lot of practical ideas as well. But we are coming on this all the time that we have. So thank you very much to our speaker, Linda Sloan Locke, as well as to Karen Amadeo, who's handling the technical back end of the program, and to all of you who are with us today. As a reminder, immediately after the webinar ends, as well as in a follow-up email, you will receive a link to post-program evaluation, and your feedback is important, so please take the time to complete. And certificates of completion will be sent via the email you provide on the evaluation and should be received in about 1 week. And a calendar of the partnership's upcoming programs can be found at www.pmch.org under the Professional Education tab. And in the coming weeks, we're hosting programs on COVID-19 and the vaccine in children, cardiac assessment of the newborn, and preventing maternal deaths, managing hypertension and postpartum hemorrhage. And we look forward to welcoming Linda back in April during Sexual Violence Awareness Month to go deeper into issues surrounding sexual violence. So look out for that in the spring. And we also have the on-demand recordings that Linda has referred to, and many of our other programs as well, on our on-demand library at pmch.org. So thank you so much. Linda, any last words before we end for today?
No, just thank you so much for having me.
Great, thank you for being with us. And thank you to everyone at home. We hope that you can join us again for some upcoming educational events.